My name is Andrew Mastro, physician assistant from Chicago, Illinois with Illinois Dermatology Institute. I am on the advisory council for the DEF, and I'm at Derm 2026 in fantastic Las Vegas, Nevada. We are on day 3, I believe. It might be hard to track all these days at this point, but I was lucky enough to be part of a panel that was called What's Behind the Curtain, and basically we got to share just case-based pearls and answer some questions that were coming from the audience that were tallied throughout the week. So the first question that we were tasked with was really discussing the concept of microdosing, isotretinoin, or the Hollywood dose as we call it. And there's a lot of thoughts on how we actually do that and for what patient type. And what we really discussed was there's a patient type that's just really recalcitrant that has been on multiple isotretinoin courses, and realistically, going through another full course for that 6 to 7 months may not be the best route for this patient, may not be responding to that third course like they did the first and second. So we talk about doing an extended course, and what that looks like can be a little bit variable. A lot of times we're working patients up to a similar cumulative dose over time, but realistically speaking, when we're doing low dose isotretinoin, it's really about mitigating side effect, making sure that we're limiting the quality of life impact. We're elevating the patient, making sure that they go through the course unscathed as we can. And that's really the goal. So it's becoming more about the quality of life of the patient, less about racing towards the end. But ultimately, we all do it a little bit differently. We talked about dosing 10 to 20 milligrams every day, up to a certain point of clearance, and then potentially even going as low as 10 to 20 milligrams once weekly. And the length of time that we're doing it for, it could be a little bit variable, but ultimately this concept of microdosing isotretinoin, we're all going to have to be aware of it because it's something that's also on social media. It's a term that is out there in the lexicon, so we have to be prepared to answer it. The other question that we got was really based around hair loss, and specifically androgenetic alopecia. And this can be really tricky. And I think a lot of us in our clinics, when we get hair loss coming into our clinic, it is one of those visits that can be very challenging. It's one of those visits that we know could derail us from the day, especially because we're seeing 30, 40, 50 or more patients. And classically, female hair loss used to be very challenging for us. Now the male hair loss that's starting really young, 18, 16, 20, it's become a very challenging patient demographic. But ultimately what we discussed was, let's break it up into how we want to treat this patient based on their wants. So the first question is going to be, what are your goals? Is it regrowth? Is it hair preservation? Obviously making sure that we have the right diagnosis. But once the patient answers that question and we can kind of then go towards a different pathway, it's really talking about the systemic therapies that are available. Whether it's, finasteride, dutasteride, or, minoxidil, and how we actually, cut that up into dosing and titration. It's really setting the patient on a correct path that can get them to their goal, but it didn't stop at oral medications. We talked about systemic therapy as well, that refers to the injections, i.e. PRP, and we talked about how we would work that into our algorithm of how we want to treat these patients. We also talked about labs and the difficulty it was establishing a protocol for these patients, especially females who come in suffering with hair loss. Do we get labs automatically? Do we pick and choose what labs we actually are giving, and what are the most high impact labs that we would choose for that patient base? The last thing we want to do is give a patient a really expensive lab set when they may or may not need it. The last question that we answered was a mismatch of what we saw in the dermatopathology, the actual result we got from a biopsy, and then what we're seeing clinically. And what we discussed was a basis of a couple different things. It sets the foundation of having a fantastic relationship with your dermatopathologist. If you get a result that you're kind of questioning or may not fit with the clinical picture, pick up the phone and have a conversation. Ultimately, establishing that relationship can really help bridge you in very, very difficult cases. But I shared a pearl that was really case-based. And what that referred to was a patient that I had that came in with a very erythematous rash, a little pustular on the inside of the arm, had a 5-month course of repeated topical corticosteroids, clobetasol over the course of 5 months repeatedly, and wasn't getting better. She saw me after that 5-month period. She came in with a biopsy. The biopsy said that it was, quote unquote, eczema. Granted, she didn't have it in front of me, but we discussed what she read on that report. She wasn't able to find it. So ultimately what I had to do was look at this rash, look at her course, and understand that she wasn't getting better. She wasn't matching what the pathology stated. She had been on these courses of anti-inflammatories and just wasn't getting back to the finish line. So what we did was we took a KOH, tried to rule out tinea in clinic live in real time. Also did a test that checked for fungal and bacteria, because when we have that pustular outbreak, this is time to really expand your differential. So when I got that result back, what it showed was tinea incognito, so a fungal infection that had gone unchecked, partly because she was on this high potency steroid for roughly about 5 months and just having this super recalcitrant case. Now she had a biopsy. That's going to be the big question. She asked me, why had a biopsy? How can this be? Well, when you take a punch biopsy of one lesion, you may not find what you're looking for in that 4 millimeter span. So even when you have a biopsy, if your histopath is not matching with the clinical presentation, take a pause, take a beat, and really put your clinician hat on again, right? Start to do the diagnosis again and step back and say, wait, this is not responding like it should be. I'm gonna reframe this a little bit. And so one of the excellent pearls that we shared was just, there's always room and time to be the clinician that has a path for your patient, that has an answer when there's a lot of different questions. And then don't be afraid to pause and just rework potentially what has already been done.